Hi everyone, I'm Dr. Anu. I'm a pediatrician and I'm going to make pediatrics simplified for you. So today we'll be discussing about febrile seizure. This is a very commonly encountered problem in pediatric setup where parents come with so much of panic and anxiety. When a child throws a seizure for the first time, these are very few things that a pediatrician must know. So coming to a case scenario, so we have a 10-month-old baby who has come to the pediatric casualty with history of 1 day of fever, history of cold for 1 day, a seizure at 6 a.m. in the morning which lasted for 2 minutes with uprolling of eyes, posturing of the body, no postictal drowsiness. There is no associated complaints with fever. On examination, child is febrile with GCS currently of 15/15. AF is flat, tone is normal, CNS examination is normal, and other systems are also normal. So in this scenario, we have an infant who has come with a history of one episode of seizure which lasted for less than 2 minutes and it's a generalized tonic-clonic seizure. So now, how will you diagnose this child? So first thing is, the definition of febrile seizure is a seizure that occurs at the age of 6 to 60 months associated with a temperature of 38 degrees Celsius or more, that is a fever more than 100.4 or higher, with no central nervous system infection, no metabolic imbalance, and they occur in the absence of history of prior afebrile seizure. So according to this, the child that has currently presented to us has a typical first episode of febrile seizure. So we'll see what are the things that we have to define in febrile seizure and what defines simple febrile seizure and complex febrile seizure and the other terminologies related to this. So coming to the classification of febrile seizure can be classified into two. You have simple febrile seizure and complex febrile seizure. The simple febrile seizure can be a GTCS. It is associated with fever. It's maximum of 10 minutes to 10 to 15 minutes and not recurrent in 24 hours. So if a child has a first episode or any episode of seizures which is associated with fever that lasts not more than 15 minutes and it is generalized tonic-clonic in nature, you call it as a simple febrile seizure. Whereas if the child has a focal seizure or if it is lasting more than 15 minutes or if it is recurrent within the last 1 day, it is called complex febrile seizures. Then what is simple febrile seizure plus? So if a febrile seizure recurs within 24 hours, it is called simple febrile seizure plus. Coming to febrile status, so a seizure that lasts longer than 30 minutes with no interictal recovery, or any child who is brought convalescent to a hospital. So if you find a child who has been brought to your emergency who is on active seizures, or if the child has had 2 episodes of seizures within a span of 30 minutes without any interictal improvement, or if the seizure lasts more than 30 minutes, then we can call it as a febrile status epilepticus. Coming to the pathophysiology of febrile seizure, so we know that infants have an immature brain, especially children up to 5 years, their brain is in a state of rapid growth. So a child who is less than 60 months has an immature brain when it is combined with an increase in the body temperature. So we know that this increase in the body temperature is caused by viruses and bacteria. They cause inflammation. So in an immature brain, when there is inflammation, there is activation of AMPA channels and NMDA channels because of the interleukins and the tumor necrosis factor. There is increased signaling of the channels, example like your SCN1A channels. All these are genes which triggers all these channels causing febrile seizure. So the genes which is associated with this are SCN1A, IMPA2, all these so-called genes will trigger the febrile seizure. So coming to the risk factors for febrile seizure, we have major risk factors and minor risk factors. The major risk factors include age less than 1 year, duration of fever less than 24 hours, and fever of 38 to 39 degrees Celsius. Minor risk factors include family history of febrile seizure, family history of epilepsy, complex febrile seizures, daycare going children, male gender, and low sodium at the time of presentation. So here we have to see that having no risk factors carries a recurrent risk of 12%. So if a patient, even if doesn't have risk factor, there is a high recurrence risk of 12%. One risk factor, then the recurrence risk is 25 to 50%. Two risk factors, it's 50 to 59%. Three or more risk factors if the patient has, then there is 73 to 100% chance of recurrence of this febrile seizures. Then there is a study that is going on called the FebStat study. So it is a prospective cohort study planned to follow children with febrile status epilepticus to study the development of hippocampal sclerosis and temporal lobe epilepsy. So in these children, an increased T2 signal in the hippocampus as compared to none in children with simple febrile seizures when imaged within 72 hours of onset of seizure. Now coming to the epileptic syndrome that will initially start as a febrile seizure. So for the first time when the child is being brought, it can look like a simple febrile seizure, but then subsequently the child will continue to have episodes of fever-provoked seizure, and then later on they will be diagnosed as children with genetic epileptic syndromes. So there are certain syndromes called genetic epilepsy febrile seizure plus. So this is an autosomally dominant condition caused by childhood onset seizures and continue past the usual age, which can be either GTCS or focal. So if a child has a febrile seizures beyond 6 years, you call it genetic epilepsy febrile seizure plus. Then can be vaccine encephalopathy and Dravet syndrome. So Dravet syndrome is an autosomally dominant condition. Onset is in males, and mostly it is seen in these infant males. Coming to evaluation and management of febrile seizures, so we know that first thing is history, because only then we will be able to differentiate between complex versus simple febrile seizure. Then coming to examination, we have to look for meningeal signs, because meningitis is a very important infection that we have to rule out in all these children with febrile seizure. Then coming to the acute management, if a child is presenting with febrile status, then we definitely will have to manage the airway of the child. We have to see the circulatory status, we have to find the cause for the seizure, we have to correct the metabolic causes if it is present. So always see the airway, breathing, circulation, disability, and administer the anti-epileptic to abort the seizure, because as long as the child continues to have seizure, there are high chances the baby can have neuronal injury. Then you estimate the recurrence risk and you counsel the parents. So there are few questions that will arise in the mind of pediatricians. Should I do lumbar puncture? Should I get a routine blood test? Should I screen for vitamin D levels and iron deficiency? What is the chance of recurrence? What are the chances of developing a future epilepsy? Should I perform MRI? Should I perform EEG? Should I prescribe the intermittent therapy? Should I start on long-term anti-epileptic medication? So all these are very common doubts that a doctor will have, especially when they come across a child with febrile seizure. So we'll see the answer to all of this. So blood investigation, as you see, the recommendation says that CBC is not required among children with simple febrile seizure, because you know simple febrile seizure is just because of the brain's immaturity. There is no need to investigate if you know that there is no other underlying cause. So if you are very sure that it's not a meningitis, you don't really have to do CBC. CBC with CRP can be considered in complex febrile seizure or febrile status. Routine blood sugar, electrolytes, calcium is not required in simple febrile seizure. Again, Simple febrile seizure does not require evaluation. Routine blood sugar, electrolytes, calcium can be considered in those with febrile status, including those ones which are being brought to emergency with active seizure. So if you have a child who has been brought to emergency with active seizure, then do consider routine blood sugars, electrolytes and calcium. Serum calcium can be considered among infants with simple febrile seizure. Blood sugar testing and calcium may be considered among children with complex febrile seizure. Sodium potassium is not required in all children with complex febrile seizure. Magnesium is not indicated. Then coming to micronutrient deficiency, all children with febrile seizure need not be screened for iron deficiency. We know that iron deficiency can be a risk factor for febrile seizure, but you don't have to routinely screen for iron deficiency. It can be considered in children who on physical examination has a pallor. Routine assessment of phosphorus, alk-phos, vitamin D is also not required. This can all be performed in children whom you think there is a risk of rickets or hypocalcemia. Urine analysis, if a child has no evidence of focus of infection, then you do urine routine in children less than 18 months. Beyond 18 months, only in children who has features of urinary tract, you need to perform urine analysis. When do we do lumbar puncture? So children less than 12 months of age with first episode who is not received immunization against streptococcal pneumonia and H influenza will definitely require a lumbar puncture. More than 12 months, all those who have been pre-treated and has been come to you, if they have been already given antibiotics, then definitely you have to do an LP. Febrile status as the first presentation. Sensorium continues to be obtained after sufficient time, and clinical features of meningitis. Then all these are the indications to do lumbar puncture. We don't have to routinely perform lumbar puncture in every children with febrile seizures. So what about neuroimaging? Do we need to do MRI and CT for all these children? So it says that first episode of complex febrile seizure with prolonged focal features definitely requires an MRI within 72 hours. What to do is MRI brain with epilepsy protocol. What do we look for here? We look for viral encephalitis features, ADAM features, intracranial space occupying lesions, cortical malformations and hippocampal anomalies. So Mayer's hypothesis says that prolonged febrile seizures will lead to ischemia, which in turn leads to hippocampal sclerosis many years later. Coming to EEG, complex febrile seizures and children with focal findings on neuroimaging, we definitely will have to do EEG. But one thing we need to know is EEG cannot be used as a prognostication tool, because even if the EEG is normal, there is high chances that the child can continue to have febrile seizures during fever episodes. So it is performed within 1 week or at the earliest, and minimum of 30-minute recording must include both sleep and awake state. Coming to management of febrile seizure, we have domiciliary care. So at home you have to put the baby in recovery position, tell them the dose and route of abortive medication, when to administer a repeat dose, and to bring the child to the hospital. Coming to intermittent prophylaxis. So do we need to routinely start these children on clobazam prophylaxis? So frequent recurrent simple febrile seizure, yes. Parental anxiety, residents far from medical facility, and complex febrile seizure who has not been started on any continuous prophylaxis can be given intermittent prophylaxis. Continuous prophylaxis can be given for children with febrile status as their presentation, if they have a neurodevelopmental delay, if they have frequent complex febrile seizures, children with febrile seizure plus or generalized epilepsy febrile seizure plus with afebrile seizures, and it is not recommended in simple febrile seizure. So we don't have to put the child on continuous prophylaxis for simple febrile seizures. So the drug of choice is sodium valproate. Anti-seizure medication should be considered for a period of 2 years of seizure-free period, or guided individually based on the primary syndrome. So based on whether it is Dravet or GFS plus, based on that clinical syndrome, we have to decide the duration of the anti-seizure medication. Remaining we can give antipyretic medication, and we have to educate the parent regarding the recurrence risk. So drugs that has to be avoided in febrile seizure, one is phenytoin and second is carbamazepine. Any drug that interferes with the sodium channel we have to avoid. Okay. So coming to the differential diagnosis, can be shivering, febrile delirium, breath holding spells, meningitis, febrile infection related epilepsy, or NORS, that is new onset refractory status epilepticus. So this is a very simple depiction of febrile seizure. We know that febrile seizure can be related, so is a genetic condition, so we have to take a good family history. It occurs mainly because of the infection triggered fever response occurring in an immature brain. It can be focal or generalized. If it is lasting more than 15 minutes, you call it complex. If it is more than 30 minutes, it's called febrile status epilepticus. Febrile status. So these can last from 6 months to 60 months. So the take home points: febrile fits is a benign age-related self-limiting condition. Clinical observation to exclude other condition is important than investigation. Early therapies to stop an ongoing seizure is very important. Hippocampal abnormalities can be both cause and effect to febrile fits in different situations. Intermittent therapy is useful to minimize the recurrence and parental anxiety. You have to restrict the use of continuous anti-epileptic drug. Hope this video helped you in treating children with febrile seizure. If you have further doubts on febrile seizure, or if you want more videos on central nervous system and the more common presentations in children, you can leave your queries and your concerns in the comment section, and I am there to help you. Thank you.